So hello. We are here at the EMA meeting, the 15th EMA meeting here in Vienna. My name is Heinz Ludwig. I'm a medical oncologist, hematologist, working at the Wilhelminen Cancer Hospital in Vienna. And my partner here is Professor Niels van der Donk. He is member of the Free University Medical Faculty of Amsterdam. And we are talking about immunotherapies for multiple myeloma. So I will ask first, my first question is, of course, which immunotherapies are available for patients with multiple myeloma needs?
Well, Heinz, at this moment we have available elotuzumab for patients that have relapsed refractory multiple myeloma with at least one prior line of therapy. And for these patients, elotuzumab has to be combined, according to the label, with lenalidomide and dexamethasone. And the ELOQUENCE 2 study has clearly shown an advantage of elotuzumab plus Lendex compared to the standard of lenalidomide with dexamethasone. So better progression-free survival, better response rate of elotuzumab plus lenalidomide and dexamethasone. Elotuzumab as single agent, may be important to mention, has no single agent activity. So you have to combine it with other agents, at least in the setting of pre-treated multiple myeloma. And then the other drug, the other antibody that is currently approved is Daratumumab as single agent for patients that have been exposed to lenalidomide, have been exposed to bortezomib. And we hope in the nearby future that also Daratumumab in combination with lenalidomide dexamethasone, Daratumumab in combination with bortezomib and dexamethasone will be improved by the European Medicines Agency. And these two triple combinations have already been approved by the FDA in the US.
So I guess the approval of Daratumumab Lendex or Daratumumab Velcade Dex combinations will revolutionize myeloma therapy, because the question is sequencing. So if patients failed after first-line therapy, what would be your preferred treatment option?
So it very much depends on the type of treatment that the patient has received in the first line. So is it a bortezomib-based regimen? Is it an IMiD-based regimen? And then also depending on patient characteristics, tumor characteristics, you have to choose a triplet these days or a doublet. And when Daratumumab triplets will become available, I think when you look at the data of all the different triplet combinations that are now available, I think Dara, Lendex and also Dara Velcade Dex are very promising when you compare it to Lendex alone or Veldex alone.
And when we compare to other regimens which have been tested just recently in the recent 2 years, which are all effective as triple combinations, but none of those, either combinations with carfilzomib or ixazomib or elo, had such a high hazard ratio. I mean, the high reduction of the risk of progression.
Yeah.
So when we look at this and when we consider this data, I think it should be logical to move to continue with then a Dara-based regimen.
Yeah. So when you have, for example, given the patient a Lendex-based treatment until progression, then it's most logical to come back with a bortezomib-based regimen, for example, in combination with Dara. When you had bortezomib as first-line treatment, then it would be logical to give Dara Lendex. And the PFS is indeed significantly higher. Also, the MRD negativity rate is much higher in the triple combination as compared to the double combination. And we know that that is a very important predictor of survival. So we expect with prolonged follow-up that all these advantages will also end up in a survival advantage of our patients.
So, but the important question is, how long should patients be on treatment? Let's divide patients into two segments. One is the patients who are responding to Dara Lendex, for instance. How long would you continue therapy? And what would you do in the other group namely those who have stable disease. So let's discuss what is the best approach in those patients.
Of course, in the Pollock study and also in the Gustuv study, treatment was until progression with Daratumumab. So Daratumumab was given in the end every month until progression. So we do not know now what is the best time of treatment with Daratumumab. Maybe in the patients that achieve a sustained MRD negativity for, let's say, 1 year or 2 years, maybe in that group we can test in the future whether we can stop treatment. And maybe these patients will have a very long treatment-free interval or may even never relapse. We do not know, and we have to test that in more upcoming trials. And I think the patients that do not have MRD negativity, maybe then, if tolerability is okay, then we should continue. And also in the monotherapy study, these extensively pretreated patients received Daratumumab until progression, so indefinitely. Now, and maybe we can learn from that study as well, newly diagnosed patients in HOVON and in IFM are treated with VTD or VTD plus Dara, induction and in consolidation after transplant. And then there is a randomization between 2 years of maintenance with Dara or no maintenance. So also from this study, we will probably learn more about maintenance and duration of maintenance. Yeah. But I think many more studies need to answer the maintenance question and the duration of maintenance question.
So let's talk about the cytogenetically defined high-risk group. Let's discuss both Elo-Lendex and, for instance, Dara-Lendex. And when we look at both groups, what is the outcome with the antibody?
Yeah, so patients with high-risk cytogenetic abnormalities were defined in both studies, in fact, by presence of deletion 17p, 1416 translocation, and 414 translocation. However, cutoffs and type of analysis were different between both, so that makes a direct comparison, of course, more cumbersome. But then in both studies, the high-risk patients benefited from adding a third drug to the Revdex backbone, or in case of the Castor, adding Daratumumab to the Veldex backbone. However, elotuzumab is not completely able to overcome poor-risk cytogenetic abnormalities. And also Daratumumab with Lendex was not completely able to abrogate the poor risk conferred by these abnormalities. In the Castor study, I think we can say that the poor risk was almost completely overcome. And then, of course, we also have other triplets like KRD, XRD, ELO-VD, in which also high-risk patients benefit from adding a third drug to the VD or RD backbone.
The only study which showed that a triple combination really was highly effective in high-risk cytogenetic patients was the tourmaline study, where there were similar results in the high-risk patient group as compared to the standard risk group with the triple combination Ixazomib and Lendex.